So what are stem cells and can they really treat arthritis, reverse this terrible condition that many, many people get where their knee degenerates? I'm Dr. John Tait. I'm a non-surgical orthopedic doc specializing in orthobiologic treatments, and this is a big component of what we do inside my practice. So in front of me on this desk here, I got these models of what arthritis is. So first I want to dig into that because there are some terms that sound similar and patients sometimes flip these around, but let's talk about what arthritis is, which is really a degeneration of the cap of cartilage on the end of the bone. That sounds like a little bit osteoporosis, which is talking about the strength of the bone itself. So as bones weaken for different reasons over life, we grade that with a study called a DEXA scan, and that can look at the density of the bone, and we can move from a normal bone to a bone that's weakening called osteopenia to a bone that's weakened quite considerably, and that's osteoporosis, where people are at an increased risk for fracture. But osteoarthritis and osteoporosis don't necessarily run in the same pack. People can have one, they can have the other, they can sometimes have both together. But if we look at arthritis, arthritis is a process by which the cartilage wears down and degrades. So I describe this to my patients a lot like the enamel on one's tooth. As it kind of erodes, and people may have experienced cavities over their lifetime, that's an erosion of this really nice hard cap that we have on our tooth, and we can get a pit or a little crack in that, and that can become a cavity. So very similar to that in the early stages of arthritis, going from a normal knee with healthy cartilage to one that isn't so healthy, we can start to get those little pits, those little cracks, that little bit of degeneration in that cartilage where people can start to become symptomatic. And the way we really evaluate arthritis, different than osteoporosis, again, that density of the bone, is we look at the space that remains between the bones. So this is how we grade it, like the models are showing here in front of me, from a knee that's not so bad to one that is really, really bad here. And we can see the erosion of cartilage there, these red patches through this cap of blue on this model illustrating that. And this is a really severe knee. This is where people get over to this stage and often are having considerable pain and problems in the knee, and they're recommended for knee replacement surgery, which is a transformational procedure. The first knee replacement surgery was done in 1968, almost 60 years ago, that we've been doing knee replacements in this country, and they've gotten better and better. The components, computer generated, we're looking at the imaging of knees, and we're overlaying that with computer assisted and robotic assisted inside the actual operating room. But to get these components dialed in and be as good as they can be for somebody after that replacement, it's just transformational when somebody has a bad knee and they can get it replaced and they can be up and around on that knee the same day. So there's nothing in orthopedics that I know that's more transformational than that when somebody gets to that end stage of arthritis. So the question is, what happens with this as the knee progresses through these stages? Because an article I read years ago said that to see joint space narrowing on an x-ray, we've already lost about 10% of the cartilage there. So when we get into an early stage arthritis, 10% of that cartilage may be gone. And we grade these 1 through 4, and 4 being the most severe. But as we progress through those grades, it may be 30% and then 60%. And then we eventually get to a knee over here that is really quite severe, and this is where people are told they have a bone-on-bone knee, because as this cartilage erodes in here, the space of that cartilage is nearly nothing, and the opposing surfaces, one side bone with that cartilage versus the other side, they almost come into a point, or they can be, where they're physically touching. And so when we get into that stage, this is a really bad knee, of course, and the treatments, conservative treatments that are typically done in the early stages, like anti-inflammatory medications or physical therapy to improve the strength around the knee or the mechanics of the knee, those are the things that start to fail the patient. The patient didn't fail. Those treatments start to fail the patient because they're just not enough to turn it around. So if we walk through those stages of arthritis here, or grades of arthritis, and then those kind of parallel the treatments that are often offered, like anti-inflammatory medications to nullify some of the inflammation and pain. Or the next step could be, again, in parallel with that, physical therapy. In some stages, if somebody starts to degrade one part of the knee versus the other, we can use mechanical offloading of those compartments with different types of braces. So those are all the things that we can be using in those earlier stages of arthritis in an attempt to change the mechanics and slow down that degradation. So, the question I get a lot in my practice is about stem cells. So what do stem cells actually do in the context of arthritis? So if we look at the end of this bone, if we were to cut a bone in half and look inside of it, inside that bone is bone marrow. And inside that bone marrow is where many cells are made in our body, including stem cells, red cells, white cells. All of our blood cells are made inside of our bone marrow, and then they circulate out into the body. And here, when we look at the context of this cartilage going bad, and we think about this as a continuous channel coming up underneath that cartilage, this is where stem cells flow through that bone matrix, up through the cartilage matrix, and their goal is to help repair that damage. So when we're a little bit younger, we may have noticed we can repair quicker. When we're a little bit older, we repair more slowly. And the repair mechanism, the master cell, repair cell of the body, helper cell of the body, is really the stem cell. So those stem cells can come up through that, bone marrow and through that bone matrix and come into the cartilage matrix beneath it and help to stimulate it from within to help self-repair. So when we get little areas of damage, the body can repair those. When we get severe areas of damage, the body's going to struggle to repair those. So along came this concept of using stem cells. So if we think about it, burning out the supply of stem cells that we have adjacent to the joint, we can take stem cells from another place in the body, like the pelvic bone or ilium bone, and we can tap into that with a simple in-office procedure and extract that bone marrow, and from that bone marrow separate the stem cells. Well, now we can take a plentiful amount of stem cells from somewhere else remote, because if we analyze what's going on here in this bone marrow, we get some level of bone marrow depletion of those stem cells. We call it stem cell exhaustion. But if we can take stem cells from another place and we can deliver them into this joint via injection, we can stimulate a reparative process. So when somebody's in an earlier phase of this, the knee isn't so significantly painful and compromised, stem cells can help regenerate, take that natural process the body does, and stimulate it to go a little bit faster, we'll say, a little bit stronger in that area where it's needed to help that cartilage self-repair. Now, there are limits to this, and this is where people write crazy things on the internet. And so I want to talk about that today, and I want to talk about how these stem cells actually work, because the first mechanism by which they work is they're able to shut off this chemistry loop, because there's a capsule around our joint, and when there's damage to the cartilage, think about little specks of that cartilage flecking off, and we call those different molecules, but we'll keep it simple. Those molecules stimulate the joint lining to make fluid. And many people think that fluid is to cushion one's knee, but it's actually quite the opposite. It's to stiffen one's knee so that you don't abuse your knee as much. So if your knee is stiff and it's swollen, you're not likely to use it as much, and your body is trying to self-repair by shutting you down. So when we ignore that, or if we just plow on some anti-inflammatory medications and keep going, right, then we can cause more damage to the knee, because the knee is asking for time and space to heal by giving you stiffness and swelling to shut this thing down. And what we've unfortunately been trained, or many people have been trained to do, is just pop the NSAID medications, and that's standard conventional treatment. But it can impact this healing process in a negative way by putting those NSAIDs in there all the time, because we actually need healthy inflammation for our body to heal. It's the first step by which our body can move over here and self-repair, right? So inflammation on the front end is necessary to heal. Many people think that's crazy, but it's actually mechanistically how the body moves through this. It moves through an inflammatory phase over a couple of weeks, and then what we call a proliferative healing phase, where now, when there's damage, these cells are attracted into that area and can start to stimulate healing. Okay, so after that phase, now the tissue can actually get strong. So if we're thinking about this in 2-week blocks, 2 weeks for inflammation roughly, 2 weeks roughly for this proliferative attraction of cells, start to get enough machinery turning in there, then we can actually get some healing and strengthening of the tissue that we aim these cells at, or what your body is naturally doing for you without having had a stem cell treatment. So we need to give the body that time and space, and that space is a minimum of 6 to 8 weeks to work through those phases and stimulate that healing and strengthen the tissue. So now, if that's able to self-repair some of the small damage in there, you can put more stress on that cartilage. It doesn't hurt, it responds better, and you're obviously less painful, more functional, more mobile, all those good things. But there's a limit to that, right? And there's people that make claims about how much of this cartilage can be restored. And when we degrade this down, when you get a sizable defect in the cartilage, stem cells have an ability to shut off that chemistry I was talking about. And just by that alone, I help many of my patients when they've failed out of other treatments, or those treatments have failed them. They've gone through the NSAIDs, they've gone through the steroids. And if I can just sidebar on steroids for a minute, corticosteroids, we've used those since the 1950s. So it's an injection of a steroid that will neutralize that inflammation, that chemistry loop. So again, it will shut off inflammation, it will shut off pain. However, it's also going to be detrimental to the joint cartilage. And this was published in 2015, by Dragoo and his colleagues, but they talked about the dose effect of putting steroid into joint and dinging this cartilage in a way. Meaning, as they increase the dose of that cartilage, or in the corticosteroid or cortisone, they damage the cartilage, right? And the dose was very small. They were talking about a single dose of 2 to 3 milligrams, or a cumulative dose kind of stacking over time of maybe 18 or 20 milligrams. And many standard injections are 40 to 80 milligrams. So it's multiples of what we call the lethal dose, or the toxic dose, to the cartilage. So if we're trying to preserve that cartilage in there, steroids are really detrimental to the joint. There's a time and a place to put a microdose in there, maybe when somebody's inflamed and they have a big swollen knee and they've worked through that initial inflammatory and early healing stage, and the knee is very painful and restricted. Well, certainly putting steroids in there may make sense to help that patient get out of that misery. But if we're doing it repetitively and we're doing it at high dose, it is documented to cause significant damage to that cartilage. So the more dose you put in there, it's dose dependent. So if you keep dosing it in there, it's one of those reasons why many patients see me and they say, well, I got the steroid initially and it worked. And then as they did the next one, it worked less. And then did the next one, it worked less. And the misconception there is that the steroid's not as effective as it used to be. But what actually is transpiring is the cartilage and the joint is deteriorating more. So the amount of inflammation in there and the ability of that steroid to shut it off is less. And so what's happening is it's, again, just like these models here, it's marching through those stages of arthritis, from an earlier stage to a later stage, which is really where we want to capture this. So, looping this back full circle, the question really is, can stem cells repair this damage in the knee? Can stem cells repair arthritis? Knee arthritis is one of the most prevalent conditions in the world. Globally, there's more disability than knee arthritis and just about any other condition as people age beyond 60, 65 years of age. So if we had an ability to use something in an early stage and not use things that are detrimental to healing, like NSAID medications or steroid injections on repeat, then the goal would be to help resupply the body with stem cells to help it heal. And what I talk to patients about is really we want to have three aspects of this, or how are stem cells helping you, the patient. It is, one, shutting off pain through a way healthier mechanism. So if we can do that, not using these things that are detrimental to the joint, we can use things that are healthier to shut off that pain loop. Okay, now the body can have a little bit more time and space there to self-repair. Again, there's limits to that. You're not going to take a knee like this and repair it completely. This cartilage surface, many of my patients are excited to see it grow before their very eyes on x-ray, 3 months out, 6 months out, a year out from their stem cell treatment. They want to see all this cartilage that they lost growing again. But what I'm trying to do is preserve the cartilage they have left, right? So there's a difference there. And so if we can shut off pain, if we can slow down the degeneration of that cartilage, the further erosion, think about it as halting it, kind of as we're working through these stages of arthritis from, a mild stage or the grade 1 knee all the way over here to 4. If we can slow that process down, and we believe that is what we are doing with stem cells, it's not going to reverse the cartilage damage completely. So the goal for treating any disease is capture it in the early stage, right? The earlier diagnosis we can make and the early stage interventional treatment we can apply, the less likely this knee goes downhill towards the end, which is the last resort joint replacement, which again is a transformational procedure for people when they need it, right? And the question is, do you need it? And a lot of that comes back to what stage of arthritis are you in? How debilitating has this knee become from a pain standpoint with everyday activities or even sleeping? And then the functionality, because a lot of people let life get small to suit their knee because they've been told maybe in their future is a knee replacement. And now they're doing their own version of, we'll say, self-preservation of that joint by not being as active, right? And they're trying to save the cartilage, if you will, by not being active. But we know on the flip of that the more functional we are, the stronger we are, the healthier, and really our joints maintain their health by movement, compressing this cartilage and getting nutrition into the cartilage and getting waste products out. So the more immobile we get and the more we shut down our function to suit the knee, the worse the knee actually gets, right? So it's kind of this reverse of what many people think. I'm saving the knee by not being up on it. And yeah, to a point, if you're doing really strenuous pounding exercise on the knee and you shut that off and start swimming instead, well, that's going to be great healthy motion for the knee and preserve some of that cartilage in the knee. But if somebody thinks that they're just going to sit and shut it down and that's going to keep their cartilage intact for a very long time because they're fearful of something like a joint replacement, then we just don't see that happening. Most people then are going to become heavier, right? Because they're not moving. They're going to develop other medical conditions. The metabolics of the body changes. And again, it's this whole concept of, the joints require movement to be at their best state of health. So if we're not moving and we just can't find any avenues for exercise to keep moving, the joint will degrade at a faster rate. And so the full circle summary of this today is, look, if you have knee arthritis and you've worked through all those other treatments, you've tried the anti-inflammatory medications, you've been to physical therapy and worked your tail off to improve the strength around your joint and improve the mechanics of that joint, so we're loading it smartly. We've then recreated our training program, exercise program to also be smart and minimally impact the knee. Maybe we've used a brace or sleeve or other components to support the knee, right? If all those things have been tried and now you're over here into the steroid shot mechanism, I would caution you going further down that path if your goal is to save your knee, right? Slow down the aging of the knee. Because right now in 2024 in orthopedics, the most powerful treatment we have right now that we have good literature and published science to support is these type of interventions. Orthobiologics like stem cells or even platelet therapy, which is, came online even earlier than stem cell therapies, but both have a plentiful amount of published literature to say they accomplish these things, right? We know they can shut off inflammation and pain through a healthier mechanism. We know they can slow down the aging of the joint, okay? And 3, by doing that, it can improve and restore the function that the patient wants without surgery. So I hope this was helpful for you today to kind of understand really, what is osteoarthritis? What is osteoporosis? We kind of covered that today. How do you grade and what grade is determining what percentage loss of cartilage in the joint? And if you're in that space of what do I do next, hopefully this helped you look out at some other options beyond what maybe you've encountered so far in your journey to help your knee pain and your knee arthritis. Because look, as I mentioned, knee arthritis is one of the most prevalent conditions we deal with in orthopedics. The numbers are growing year over year. And globally, there's more disability than knee arthritis than just about anything else because of the amount of time you can live with arthritis could be decades. So if you've already had a problem with your knee for months or years, best time to act would have been years ago. The next best time to act on it is probably now to look at some of these treatments. So if that helped you in any way, please like the video. Subscribe to the channel if you like content like this so you know and you get an alert when new things come out. And if you could, drop a comment below or questions on future content that I can make to help you understand some of these treatments that are out there now in 2024 that can help you feel better, have less pain, and keep doing what you love doing.